So I would like to thank you all for still being here. And I would like to thank especially the NNI and you, Natalia, for having us all here and taking very well care of us, and for organizing this wonderful seminar, workshop, workshop. Okay. So the first thing I would like to say is that just as a little summary, Martin had a very nice talk and set the stage, actually, with all the issues or several issues around medical school nutrition education, provided some solution with his program, the NIM program. And following that, we had Shimon, who really has shown us that if you really set a pathway, you're able to provide solutions that are really adapted to the problems and as more of a global view on the issue, and with an interaction between the education, the research, and the implementation. In my case, what I will do is to use the case of the US and tell you a little bit about what's going on there, all the ups and downs we have had, and how we are moving towards more of a potential solution using a platform that would encompass government, non-government, organization, and industry. So without waiting, I would like to mention to you that I'm very lucky. I was the co-workshop chair at the NIH for one of those education, training, and research workshop where we have been talking Shimon and Martin were there too. And I have been the co-committee chair for NEPS at the American Society for Nutrition, and where both of our friends are into. So I'm doing this for the American Society of Nutrition with support from Gwen Twillman, who is the Vice President of Education and Development at the American Society for Nutrition. A little disclosure, my other support and my employee is Boston University. So in terms of objective for today, I will just summarize a little bit the nutrition state and shifting models of education in the US context. We'll give you some key goals from the NIH Nutrition Academy Award programs and the follow-up workshops that have been done over the years, and then describe how a coordinating center led by the American Society for Nutrition may support the advancement of the field in medical nutrition, metabolism, and lifestyle. So where are we now and where are we going? So we have talked in the different lectures about the fact that the nutrition was up there in terms of associations with mortality. We have talked about physicians not feeling prepared, problems of standardized education and training, the data from Martin showing that 1/3 of the medical schools provide the recommended 25 hours over the 4-year curriculum, and how there is an increased failure to require nutrition education. And unfortunately, there's very little known for residency and fellowship programs. There's a little bit of work done around GI, but otherwise very little. So what are all the difficulties and the steps that we need to integrate for nutrition to be in the medical curriculum? So, and why do I speak about integration? Integration now is probably the only way to go, and I know Martin is going to jump at me for saying that, but there is no time, there's no space in the curriculum in the medical schools. And geriatrics had to do that, and drugs like heroin, they have had to do that to integrate themselves. And they have done so very well. So why not us? So there are issues with program leadership. How do we get support? How do we get the faculty interested and the students? Should we do something vertically, horizontally, both of them? Should we do a course? How do we get funding? Should we have it, not? Should we create material, or should we use some of it, and where is it? Should we use ambassadors, advocates? And how can we improve the skills, not only of the students, but the educators? How do we evaluate improvement, and how do we work with sustainability? So lots of questions. We don't have many of the responses, and so this is a work in progress. But I think the important thing is that we don't only work on content, but on process. And many of the speakers these past few days have shown that that's what they have done. So here I would like to show you a few models from a few champions across the US. It's not exhaustive, but it's just a few examples. So a few examples of models where there's been a course. It may be there or not there. Some models where it's based on culinary, and that's very catchy right now. It looks great, people are very excited about it, and guess what? It makes the news, people hear about nutrition, and if anything, we have increased awareness, which is great. And there are programs that are more electronic-based, like Martin. There are some that are dietitian-driven. Some are integrated, using different aspects of integration. Some are student-centered, like our program, Health Professional Society Center, like the Michigan State program, and some are really focused more on exercise physiology, and there is a group in Greenville with support from the Lifestyle Medicine Collaborative that has made a lot of noise, at least among the champions in nutrition education. So I will just touch base a little bit, it's the only slide I have on what a medical student group can do. So this is our model. It's centered on the students, and we have a program where we have faculty and student interacting, and we have had over the past, I don't know, since 2005, we have been trying to integrate nutrition in the curriculum, and we have all the steps going from assessment to implementation and evaluations and so on. And so you can see that the group that's called SNAC is our group of interest of nutrition in the medical school. This is one of the groups recognized by the dean. And they do a lot of different things. They are involved in community work, they're involved in medical education work through events, through inviting presenters who are champions in nutrition. They can be dietitians, they can be mental health providers, a whole array of speakers. They help get nutrition in the curriculum, identify where the holes are, and they publish. They have published with us in books. They have published posters. They have talked at different symposiums. So they're very, very active. And one of the wonderful things is what I was talking with Martin a few minutes ago, is that pushing from above doesn't always work. You need to push from below. And what I think is really useful is the sandwich method, where they both are working to really pressurize the system. And I will tell you, and that I talked to you about this, Ellen, there is actually a world report on colleges that came out last year, and they were making some reference to the fact that the millennials are very interested in healthy lifestyles. And so now they're starting to look for colleges that are offering some healthy lifestyles. Is there a gym? Is there a cooking demonstration thing? Is there programming? And so on. So that's a great way to leverage things. So I think we will hear more of that. Because at the end of the road, what we need is to not force, but help the deans and the decision makers to make a change. And how do you make a change? If you lose students, and that costs money, right? Or your students are failing because questions are on the exam. So those are things that we can all work on. So what about the shifting models of education? So in the past, we were very content oriented, and now we are more outcome oriented, and that's in general for every discipline. And the path of learning is not anymore hierarchical, And it's more the student that is involved rather than the teacher. The teacher is there for support, and there is a lot of research done through computers and through discussions between students. So the role of the teacher has shifted, and the competence of the teachers don't need to be as exhaustive as before. And it's not so much knowledge acquisition, but application. So big shift in the model. And so here you have a little summary of where we are in terms of a competency-based education model that's based on a frank source and also an enormous work from Olten Kate, who is actually the person who started the movement on assessment of medical students through something called EPAs. And it's entrustable physical professional activities. So on the top of this picture, what you see is that it's the health needs and the health system that should be determining the training outcome that's needed. And that's what drives the curriculum and assessment. And in the assessment, you have 3 different blocks. You have the competencies, which basically is the physician's descriptors. That's where the attitudes and the knowledge and all those things are coming into. And you can have domains of competencies or sub-competencies, which are knowledge, attitude, and value, and practice. Then you have the EPAs, which can present themselves in many ways. You can have one. Let's say, for example, you do a nutrition one. You have one nutrition EPA. You could have 2, one ambulatory and one for one specialty, for example, for pediatrics. You can have one ambulatory and one inpatient, or you could have 10 different ones because you want to focus and have multiple competency per area. The only caveat is that the medical school, the residency program, the fellowship program, they don't have time, they don't have enough staff, and the less cumbersome the competencies, the more likely they will endorse some of those. And in terms of milestone, the only group that I'm aware of that has really worked on all of them is pediatrics. And it's basically a behavior descriptor. And so what it is that it's going to look through all the 4 years what your level of competence is across the 4 years, and if you are the level of 3rd year, or your level of 1st year, or your level of 4th year. So, and this is what I was just talking about. So you go from knowledge to action, and so you novice at the beginning to expert. And so this is the progression that you would expect, and milestone is a way to assess that. And so definitions are very important, and there's been a really mixed information across all of us. We have suffered of it, but I think we have good definitions now for what competency is, what competent means, and what competence is. And I'm happy to leave the slides to the NNI if people would like to have a copy of them, because there's so many definitions and items that may be useful. Here I have a little application. We have done an EPA for our residency program in nutrition, and only one, and that's in the ambulatory setting. But what I want is to show you where things are. So if we look at the domains of competency, those are 6 domains that every specialty or every, every subspecialty should be integrated in. Then you have the competencies that are very short, and you can have sub-competencies that go into them that are known as knowledge, skill, attitudes, and now values. Those have been added. So as an example, if we take the system, where is the system base? So if we look at the, Yeah, so if you look, for example, at one competence domain, that's system-based practice, You could have a competency that's work interprofessional teams to enhance patient safety and improve patient care quality. So that would be the competence. And one of those KSAs could be understand the role of health professionals and refer the patient and or the family for further evaluation and counseling to specialists and multidisciplinary specialty clinic where appropriate. So you can see how it's a little bit like a tree. You have a larger item that goes into one of those 6 competencies. Then you can have a few of those knowledge, skill, attitudes, and then you can identify and quantify at what stage people are using milestones, and that's the story of our competency-based educational model at this time. And the initial EPA that was put together was basically for the residency program, but now the AAMC has suggested to and wrote a whole manual on how we should be focusing on medical school EPAs by looking at what we expect them to be able to achieve when they enter in residencies. So we can have those EPAs across the entire spectrum of training. So as you have seen in so far, the key words are assessment, behavior, skill, outcomes. And it seems that we are shifting to a competency-based model, and milestones, competencies, and EPA will provide a framework for assessment across the educational continuum. And so it's important we know all those things, because if we want to fit in, we have to understand what's going on. There are different boards of examiner in the US that have in the past included nutrition and lifestyle questions in their test, but they're very few. The LCME has some standards and require that the schools that are accredited follow those standards. And as I was mentioning in one of my, I think it was when Martin was presenting, it's important to understand that LCME doesn't dictate anymore what the schools need, what the students need to know. And they measure how good the school is by the objectives the school is putting in the forefront and how well the students are matching those objectives. So very different ways. So it's really a decentralized process at this time. So more on the medical schools. And of course, collaboration is critical to get all those things through. So now we'd like to shift gear a little bit and talk about the Nutrition Academic Award. Anybody has ever heard of that? No? Oh, very interesting. Nobody? Except the two? Yeah, I know, you two, no. No? Okay. So you see how siloed we all are. So the Nutrition Academic Program was actually initiated by one of the NIH branch, the NHLBI. So it's the branch that's dealing with the heart, lungs, and blood. Also other branches were associated, such as the NIDDK, which deals more with diabetes and nutrition, but they all do a little nutrition now. They're all supposedly integrated. So what they did is to establish a grant in 1997, and they awarded to schools. I believe there were around 21 schools, and then they had a second award to a few less schools, around 10. And what they wanted was to establish a network of US medical schools, try to develop a curriculum guide, incorporate nutritional guidelines in the competencies, and evaluate material and clinical assessment tools, and see if there was a feasibility or effectiveness of nutrition curricula, materials, and teaching tool. They also established a website and collaborated with different nutrition organizations. They did a lot of work. They were very well organized. As you can see, there were people and groups overseeing curriculum development, medical education, and evaluation, and then they worked on material, nutrition education research and development, and they tried to disseminate the work. So the work was disseminated by publication in the American Journal of Clinical Nutrition and was also disseminated via their website. But when I talked around me, nobody knows about it except a few physician nutrition specialists. So there is really a problem of communication. And so in terms of deliverables, there are a few examples here. They came with knowledge, attitudes, and practice skills for medical students, residents, and fellows. They had some material. I don't know if anybody have heard of the WAVE REAP from Brown University. That's something that's still utilized by physicians, but more in the adult world than the pediatric, because it's really not pediatric compatible. There were programs that were developed, like at Tufts or Harvard or University of Colorado. And there were different surveys, tools that were developed. And all of that was on the website. And here's an example of NAA objectives. So those are the knowledge, that's how they call them, knowledge, practice, skills, attitude. There is no value in this. This is a new term that has just surfaced in the literature. So here, let's take an example. They were saying, okay, someone who is a medical student should be able to list laboratory measurements commonly used to assess the nutritional status of patients. And there were around 400 of such objectives. So laundry lists, deans didn't know it existed. Very few people used them. Some champions in nutrition in medical school used them, but it was really a minority. And one of the problems is that there were gaps when these awards were completed. There was still a need for standardized and validated nutritional assessment method. There were a need for nutrition guidelines that were endorsed. There was a need for training and certifying practitioners on this. And so there were still a lot of problems, and nobody measured what the patient impact was. And one of the big problems was that all this effort had been done in silos. There was no coordination of those efforts. There was no plan on sustainability, and everything just fell down. There are few schools still work very hard, and we'll talk about, but it's really a roller coaster, because every time your deans change, your champion goes away, everything has to be restarted from scratch or about. So in 2012, the NIH had a workshop in follow-up of that to try to see where things were standing. And they wanted to look on the content and implementation of nutrition and healthy lifestyle education training and competency testing across the continuum of medical education. But they wanted not only to focus on physicians, but also bring the other healthcare providers. And they were thinking about integrating medical nutrition education, training, and research into patient care. So those were the intending outcome from this group. And so here you have a little bit more verbiage on what the objectives were. And one of the big things were that there was a push to reformulate the current curriculum guide with the 400 how would you say, the 400 objectives. And one of the things also that came out of that was, okay, we are lacking a coordinating center. How can we work on this and try to have these efforts come all together? So 4 publications were out, and there were a review of the state of education. There was a paper on residency, what were the limitations, where were the weaknesses, where were the strengths, what could we do? and similarly for medical students. And then there was also a other healthcare professional approach that was put together with this, which included the nurses, the dental, and a few other groups. And you can find those publications online from 2014. And so we're back in 2017, and we want to look at this again. And so what came out of that workshop was to recommend to update those curriculum guide, but that would help us develop the EPAs that are within this shifting model now, competencies and milestones. And so the idea that was floated was that we could, through this guide, inform the development of EPAs like family practice, pediatrics, internal medicine, to cite a few. And that would be very useful because there is really nothing that looks at how do you assess your patient, your students. And from there, you can then develop competencies per se. So the implications were to develop a coordinating center. And so the high priority that was identified was that this would be enabling the organization and the perpetuation of nutrition efforts in medical education and related research. And it should be concentrated on the continuum of medical education. And so this could be done through subcommittees such as research, GME, which is graduate medical education, UGME, which is undergraduate, and CME, which is continuous, so for the physicians who are in practice. And so the idea was that there would be representatives and support and advice from different organizations and trainees. And so here are some of the reasons why a coordinating center could be led by the American Society of Nutrition. The first is that the journals are very strong worldwide, and there have been key papers that have been published about the remodeling of nutrition education in 2014, that ASN has been involved in developing best practice in public-private partnership, that ASN has been meeting multiple stakeholders, and they have approved a coordinating center, which is a big step ahead. There have been some planning committees that have defined what the effort, scope, and the governance structure, and the timeline, and so on should be. And the ASN also has been working in a collaborative to revamp those objectives and improve them with an international association. I forget the name. Can you tell me? It's so complicated, Martin. Okay, medical science education, thank you. And so it's the ASN that partner with YAMS that had already done a first set of those updates. And Martin very kindly allowed us to use his network, which is a network of champions in nutrition, and was very useful for this. So this is ongoing at this time. So what are the goals of this coordinating center? It's first to advance a broad-based educational effort to improve nutrition in medical education, but that within a collaborative on education and training with input from different health professionals who deal with some nutrition and lifestyle and facilitate research. And I think a keynote I added because of all the talks we heard in the past few days. First, one of the things we want is that it's evidence-based, interprofessional, and collaborative. But I think we could use some of the lessons learned from several of the folks who have been presenting here. And I'm thinking about you in particular with the British Nutrition Foundation, because we have had a lot of lessons learned through education and teaching the teachers. And then the Philippines, I think, is a great model because there is really a centralization of all those things. So I think we will be talking with you further. And those are the areas of focus of the coordinating center. So resources, community building, confirmation of the objectives, capacity building, PNS, so certification of physician nutrition specialists, research and advocacy. This is the model that has been proposed with an advisory board, recommendations from groups like the NIH, for example, the LCME, also input from a strategic planning where you would have government and non-government representatives that are familiar with EPAs, that are familiar with nutrition curriculum, and then the center with this platform really working on different committees that would oversee research, undergraduate, graduate, and the CME. So trying to push on the tools development, web-based access to information, and so on. So a big plan here. For the moment, we just have a few partners with the NIM is one of them, Martin is there, and we have also, we're also working with NetPro, and actually we put one grant through with you guys. Hopefully something comes out of it. And we have also ideas about future partners. It will be very open to other health professional societies, board of examiners, foundation, and so on. And so there are different activities that will be more short-term and then others that are going to be more long-term. And the long-term are basically to try to expand what we have learned so that we have a better interaction between what's taught in the health professional professions versus the RDs and the physician nutrition, and also expansion of educational efforts globally and in partnership with NetPro to begin with and probably others. So I would like to thank a lot of people, Gwen Twillman and Stephanie Dunbar at ASN, the NEPS committee, which is a group that focuses on education. Cheryl Rock has been leading with Ed Salzman, the coordinating center structure and governance and all those things. And I'll thank them for doing that. Doug Steidner, Lisa Hark. So we have dietitians, we have MDs. We have a very good representation of people who are not only ASN members, but also members from other societies. And we even have a participant from the bipartisan group. I'd like to thank also the NIH with Charlotte Pratt, Linda Van Horn, who is my co-workshop chair, and also in YAMS, Lindsay and Thompson. And I think that's about it. Thank you very much.